Hi, welcome back. Professor Schimmel here, and we're going to start part 2 of the lecture on mycoses, which of course are fungal infections or conditions caused by fungi. Picking it up with the second category, this one's known as cutaneous mycoses. You can follow along and take notes with your outline. As it says in your notes, the cutaneous mycoses are also known as dermatomycoses. The reason for that is that they're caused by a specific group of fungi called the dermatophytes. And what the dermatophytes are especially efficient at is the digestion of the protein keratin. Keratin, of course, is found in hair, skin, and nails. You're going to see a lot of similarities between this group and the last one, because they are going to be fungal infections of the hair, skin, and nails. But this group tends to be, the infections tend to be more invasive and more difficult to actually successfully cure. So that's why they're given their own special category. All right, so transmission would be, once again, by either direct contact. And when I say direct contact, I mean with an infected individual. That could be another human, or that could be an animal like a dog or a cat, for example. So transmission is by direct contact or by fomites. And level of tissue infected, well, these are infections of the hair, skin, and nails. As I mentioned before, tend to be more invasive than the previous category. In some cases, they may respond well to treatment with an over-the-counter topical. Some of the examples I gave you in the previous category would work. And in other cases, we may require an oral medication. Little disclaimer here, whenever I indicate a treatment for a particular disease or condition, I'm just giving you one of likely numerous possible appropriate treatments, so just keep that in mind. Okay, so first example of a cutaneous mycosis is a disease called Tinea capitis. And as it says in your notes, there are a number of species of fungi that can cause this infection. For example, several members of the genus Microsporum and a number of members of the genus Trichophyton can cause this disease. Just a little note, maybe I'll make you a little card for this. When you're talking about scientific names and let's say all right, so I'm just arbitrarily using the name, the genus name Staphylococcus for this little discussion. But anyways, sometimes when we are referring to multiple species in a genus, for example, causing this this disease known as Tinea capitis, and I'm just using Staphylococcus as an example here, guys. If we are just wanting to make a general statement about someone in the genus Staphylococcus, we would put SP after it, meaning a species in the genus Staphylococcus. And if we are referring to multiple species in that genus, then we would put SPP after the genus name. All right, so when I say caused by Microsporum, that's a genus name, and then the SPP means multiple species in that genus, and then ditto for Trichophyton. Okay, anyways, so a number of fungi in that in those two genera, I should say, are the typical cause of this disease known as Tinea capitis. Okay, let's talk clinical characteristics, and you've got a photograph of an unfortunate individual on the next page of your outline. Typically, this is a scalp infection, and in this case, rather than just, do you remember in the last condition, that Blackpedria, we saw the fungus actually growing around the hair shaft? Well, this particular disease is more invasive, and the hyphae of the fungi are going to actually grow down into the hair follicle. And just to refresh your memory, the word hyphae refers to a long filament of mold cells. So those filaments are going to actually grow down into the hair follicle, and that will cause the death of that hair follicle. Okay, so clinical characteristics continued. Scalp infection, hyphae are going to grow into the hair follicle. And so we're going to see, as you do in that photograph in your notes, patches of hair loss, bald patches, and this may very well be a permanent condition. Now, normal flora of the scalp will have a tendency to infect these fungal sites of infection, causing secondary bacterial infections, including pus-filled lesions on the head. And this happens to be one condition that may be a zoonosis transmitted by infected animals to humans, like maybe a child pets an infected dog or cat. Child doesn't realize that the animal's skin doesn't look healthy, so doesn't wash their hands, and then maybe does something like that. So that's one way that an individual could be infected. Now, this can be diagnosed with what's known as a Wood's lamp. It's a type of fluorescent light. It fluoresces at 365 nanometers. Just wanted to make sure I didn't make a mistake there. 365 nanometers. They have handheld units of these Wood's lamps in most veterinary hospitals and medical offices. And if you shine that Wood's lamp over the infected area, it will fluoresce, and that's a diagnostic tool. Okay, geography. This is a common disease. It has cosmopolitan distribution. Population. Now, this can occur in anybody, but it's most often seen in pre-adolescent children. Like I said before, maybe their hygiene or their level of consciousness as far as that sort of thing isn't as good as we would see in an older individual. Predisposing factors would be contact with infected animals and poor hygiene. Also, the skin being wet for a prolonged period of time through sweating or swimming or whatever. Now, generally speaking, dry skin, I don't mean like, clinically dry skin like they show in the commercials, but I mean, you took a shower and you completely dried yourself, you went swimming, you completely dried yourself. Dry skin is healthier than allowing your skin to be wet for prolonged periods of time. What fungi like to grow, the conditions that they prefer are moist and warm conditions. So if we can eliminate the moisture, that's going to make it more difficult for them to gain a foothold. All right, so we did predisposing factors. Treatment. Now, a medicated shampoo containing the ketoconazole may do the trick, or you may need an oral medication. I'm not positive I'm pronouncing this right, but I believe it's pronounced griseofulvin. I know there are some newer age meds that may be given orally for this, but that's kind of a classic one. Okay, let's move on to tinea cruris, also known as jock itch, a reference to the male garment known as the athletic supporter or the jock strap. This one is caused by trichophyton rubrum, seriously, and clinical characteristics. Now, this typically begins as an infection, let's say in the skin folds in the groin, and in severe cases it may spread to the buttocks, even the trunk of the body, and this can be anywhere from a mild irritation, maybe the individual has a small patch of moist, painfully itchy skin. I mean, that would be the not so bad end of the spectrum for this disease, all the way up to, in very severe cases, and they may be chronic, may be very difficult to cure. In the severe cases, we're going to see raised, scaling, weeping lesions on the skin, and these may bleed, they may become infected with bacteria, normal flora of the skin. This can be a short-term problem or a lifelong problem. Okay, geography, well, this is a common disease, cosmopolitan distribution, but even more common in the tropics. Population, 3 times more common in men than in women. Common situations where we might see outbreaks of jock itch would be places where people congregate, high densities of individuals living together, like in prisons or on shipboard institutions, for example. So that sort of a situation. Let's see what else I wanted to tell you. Oh yeah, I wanted to mention that women wearing those skinny jeans, those really, really tight skinny jeans, see a higher incidence in this type and other infections just because of the irritation of the clothing. Sometimes women will get this infection under their bra, like the underwire area, because you know the bra is chafing the skin and moist, warm area, especially in the summertime. And if the mold or the fungus is present, the female patient may develop an infection in that area. Okay, may also be spread by fomites. Treatment depends on the severity. You should keep your skin clean and dry. Avoid irritating clothing if possible, and start with an over-the-counter, just a general antifungal ointment or powder. Start with that. If that doesn't work, then you need to go and see your doctor. Medications that contain the drug known as Mycoses tend to be very effective for this infection. Okay, and one more example in this category, and that is tinea pedis, or athlete's foot. And this is the most common fungal infection. This is extremely common. Caused by Trichophyton mentogrophytes and others, but that's the most common culprit. Clinical characteristics, well, this infection usually begins between the toes, moist and warm, right? Usually begins as a patch of, again, painfully itchy skin, and this can be a small problem or a large chronic problem. Pretty much the same description I gave for jock itch is true here, except, feet. Starts between the toes, can spread to the sole of the foot, the top of the foot, and can progress to those raised, scaling, weeping lesions that I mentioned before. You've got to keep your feet clean and dry, so that means paying special attention to drying, like between your toes after showering or bathing or swimming. If you want to also be very careful, well, I guess I'll talk about that in predisposing factors. I'll come back to situations where you might be exposed. But anyways, trying over the counter, they sell a number of things. And if that doesn't work, then you need to see your physician, and you need to be quite careful about being aggressive and really getting rid of this, or you're going to deal with it for the rest of your life. Okay, so let's see. Geography, cosmopolitan distribution, more common in warm climates. Population, anybody can get this, but it's rather unusual to see in children less than 10 years of age. The predisposing factors include moisture and warmth, and exposure to contaminated surfaces. I think this is probably why younger people don't get this as often. We're talking about walking barefooted. This is why you always get nagged about don't go barefooted in public showers or gymnasiums, right? So contact with contaminated surfaces, and then the moisture and warmth, those are our predisposing factors. Treatment, again, depends on the severity. Dry your feet, especially between your toes. Lotrimin, tenactin, they may be effective, and severe cases may require an oral medication such as griseofulvin. Okay, let's see. Next is the third category, subcutaneous mycoses, and these are, as the name of the category suggests, infections that at least begin beneath the surface of the skin. That's how they start, and they are caused by a group of fungi known as the saprophytes, and these fungi live in the soil, and they are decomposers of organic material. Transmission is usually by a puncture wound where spores and or hyphae are implanted beneath the surface of the skin. And level of tissue infected, well, there's subcutaneous infections, at least initially. All right, let's talk examples here. The disease known as Chrommycosis is my first example, and the name is given. Let me just look and see what you have in your notes. Oh, that's an ugly picture of athlete's foot there, huh? What do you have? Yeah, you do have that note in your outline. What I was referring to is that the name Chrommycosis means fungal condition with Okay, sorry about that. Phone rang, dog started barking. Let's pick it up with Chrommycosis again. And already talked about, name is due to the dark pigmentation of the hyphae of the organism, caused by, my best guess here, you guys, Fungi pedrosi and Phyllophora variecosa and others. Clinical characteristics. Holy cow, take a look at that picture, huh? Now, this is an infection that usually occurs on the leg below the knee, so lower leg or the foot. And this occurs especially when an individual has close contact with the soil and doesn't wear shoes. Now, it isn't because they're having fun running barefooted in the grass. This is typically in underdeveloped nations, agricultural workers that don't have shoes, and so that's why they are getting these infections. Now, what's going to happen is a puncture wound is going to implant hyphae or spores beneath the surface of the skin, and so we're going to see the development of ulcerated, that means opening, lesions, and they begin to develop beneath the surface of the skin, but as they gain size, they will erupt and continue to develop, these masses develop above the surface of the skin into what they describe as being cauliflower-like masses. It sounds pretty awful, and as you can see in the picture, it is awful. All right, these lesions may persist for years, and just think about walking around like that, you guys. I mean, you bump them, they get abraded, they bleed, secondary bacterial infections. Not a good situation. Geography, primarily South America, and the population is most commonly seen in men between 30 and 50 years of age. That happens to be the segment of the population that are mostly agricultural workers. Predisposing factors, not much known, let's say acquiring the puncture wound. And treatment, there is a medication called amphotericin B. This one's going to be given by IV. Not much information about optimal dose or duration. And then we're going to have to surgically remove the lesions, which I don't know how likely that is. If these folks can't afford shoes, they probably don't have medical care available to them. Okay, let's move on. Another example, and then I will wrap up this segment, and we'll finish the last two categories in the third installment. All right, next is a condition known as Sporotrichosis, caused by Sporotrichosis. This is a mold that lives in soil, on plant material, moist wood, moist rotting wood. Puncture wound, of course, is going to cause this. Oh, actually, before I get into the subcutaneous form of this disease, I wanted to mention this same organism, if inhaled rather than acquired through a puncture wound, can cause a respiratory infection that can become chronic, like a chronic cough. But now I want to talk about the subcutaneous infection. All right, so we had a puncture wound, and we're going to see the development of more localized lesions. You can see them on the arm of the patient in your outline here. They do ulcerate. I find it interesting that they're described as being minimally painful. I don't know about you, but that looks pretty painful to me. All right, geography, cosmopolitan, but more common in Central and South America. Anybody can get this. Predisposing factors, again, not much info there, but I think that acquiring the puncture wound would get us there. Treatment, now if it is a puncture wound, and this is going to sound curious, but I've looked it up a few times, the puncture wound will be treated with a saturated solution of potassium iodide that will be taken 3 times a day orally. It's mixed with either water or milk, and they add sugar because it's apparently very bitter. The respiratory infection, should it become chronic, IV amphotericin B again. Okay, I'm going to break here again, and when I come back for the third installment, we'll talk about systemic and opportunistic mycoses. Thanks for watching.